What's up, everybody? I'm Dr. Jordan Taylor, the Undergraduate Exercise Science Program Director and Associate Teaching Professor at the University of Kansas. Once again, I've invited Dr. Dan Lorenz back to the studio, and today we will be discussing Little League elbow and ulnar collateral ligament injuries, which are both common overuse injuries that affect the elbow of overhead throwing athletes, such as baseball players, primarily pitchers. Dr. Lorenz is currently the Director of Sports Medicine at Lawrence Memorial Hospital, Ortho, Kansas, in Lawrence, Kansas. He earned a bachelor's degree in health sciences with an emphasis in athletic training from Grand Valley State University in 1999 and a master's degree in physical therapy from Grand Valley State in 2001. In 1997, he was an athletic training intern for the Chicago White Sox Major League Baseball team. From 2004 to 2005, he completed the Duke University Sports Physical Therapy Fellowship. Formerly, he was an assistant athletic trainer and physical therapist for the Kansas City Chiefs from 2005 to 2007. And in 2009, he earned his Doctor of Physical Therapy from the University of St. Augustine in St. Augustine, Florida. He is the former chair of the Sports Performance Enhancement Special Interest Group for the American Academy of Sports Physical Therapy. In 2018, Dr. Lorenz was recognized by the National Strength and Conditioning Association as the Sports Medicine and Rehabilitation Professional of the Year. And he's been published several times in peer-reviewed journals and has been an invited speaker numerous times at local, state, and national conferences in sports medicine. Welcome back to the show, Dr. Lorenz.
Great to be here, man. Thanks for having me.
Yep, appreciate it. I want to provide a brief overview of the elbow joint and its associated anatomy before Dr. Lorenz and I discuss Little League elbow and ulnar collateral ligament injuries. So the elbow joint is classified as a gangliomous or hinge-type joint that allows only flexion and extension movements. The elbow may actually be thought of as three interrelated joints: the humeral-ulnar, humeral-radial, and the radial-ulnar joints. Elbow motions primarily involve movement between the articular surfaces of the humerus and ulna. Elbow joint stability is increased when the elbow is fully extended, but as the elbow extends approximately 20 degrees or more, its bony stability is somewhat unlocked, and that allows for more side-to-side laxity. So the stability of the elbow in flexion is more dependent on the collateral ligaments, such as the lateral or radial collateral ligaments, and especially the medial or ulnar collateral ligament. The ulnar collateral ligament is critical for providing medial support to prevent the elbow from abducting, which is not a normal movement of the elbow when stressed in physical activity. Many sports that involve overhead movements, such as throwing a baseball, place stress on the medial or inside aspect of the elbow joint, resulting in injury. The ulnar collateral ligament is particularly crucial to those high-velocity sporting activities such as baseball pitching, which require optimal stability of the medial elbow. Even moderate injury to this ligament can seriously impact an athlete's ability to throw at the highest levels. So we'll go ahead and pull up picture one here just to take a look at some of this anatomy that I was describing. So you have a couple views here of the elbow. So you see a lateral view there at the top, and this would be the right elbow. So let's just name the bones here that make up this joint. The humerus, that's the upper arm bone. The radius is on the thumb side of the forearm, and then the ulna is the pinky side. Now, typically, if the forearm is placed in this position where the hand where you're supinated, like you're holding a bowl of soup and the palm is facing up, that radius on the thumb side is going to be parallel to the ulna. But if you look at the head of the radius, that part kind of pivots and rotates alongside the ulna. So if you pronate, turn the hand down, they actually form an X, those two bones. So the radius crosses over the ulna. So those are the bones that make up the joint. Like I said, most of the movement when we're talking flexion and extension occurs between the ulna, the pinky side forearm bone, and the humerus. And then if you look at a posterior view down there on the lower left side, you can see the back side of the elbow. So you see like the olecranon process, the medial and lateral epicondyles. That's where some of your forearm muscles attach. So like your wrist and hand flexors all attached to that medial epicondyle. And we're going to be talking kind of a lot about that area here in a bit with Dr. Lorenz. The lateral epicondyle, you have a lot of the wrist extensors. So you think about, cranking your motorcycle up, all those muscles are contracting and attaching to that lateral epicondyle. So that's a posterior view. Then the anterior view, this is the front side, so you see the humerus there again, and how the radius and ulna run parallel, and then those two condyles, the lateral and medial, where we have a lot of different, musculotendinous attachments. And so then if we go to picture two, we'll pull that up here. That'll be the next image that I want to talk about. So now that you understand the bones that make up the joint, let's look at the ligaments here, because we're really going to get into discussing the ulnar collateral ligament, which you see highlighted, kind of those three parts there in red. That again is on the medial or the inside aspect of the elbow, and this is what's frequently injured in baseball players, pitchers, catchers, quarterbacks, anybody that's involved in high velocity throwing, repetitive use. So we're going to be talking a lot about that ligament. Dr. Lorenz and I. And then you can see just a lateral view, some of the other ligaments that hold the elbow joint together. Okay, Dr. Lorenz, so now that we reviewed elbow joint anatomy, let's discuss Little League elbow. What is Little League elbow, if you can just kind of provide a definition of it? It's technically termed medial epicondyle apophysitis. And then maybe talk about the causes. What causes this condition?
Little League elbow is really just an inflammation in the medial side of the elbow. It certainly could be muscular, but oftentimes, especially in skeletally immature young athletes like Little Leaguers, the apophysitis piece is where the bony attachment of the flexor mass on the medial side of the elbow is inflamed, oftentimes leading to where the bone can actually start to pull away where the growth plates are. So that's usually why it happens, and it's quite simple for the kids. It's mostly just overuse.
So which would be like an avulsion fracture if
Yes.
that bone is starting to get pulled away. And then, it can vary. I know like what you see, like say with imaging. So it seems like in some cases, like you see the growth plate there, and this is not all cases, right? It's like, but sometimes there is like a widening of that growth plate.
Yes, there can be from repetitive throwing.
Right. Okay. I think we have an X-ray image of that coming later. And then, as you kind of see on this image, on the medial aspect, if you think about the throwing motion, especially as we're going to get into looking at where the most valgus stress is on the elbow. So there's tensile stress with high velocity throwing on the inside of the elbow, and then compressive forces on the lateral side, especially in that late cocking phase and then that acceleration phase when you're accelerating the arm forward. Anything you want to add there with we're going to get into the pitching mechanics, but I guess other causes?
That's largely what it is. We're right now in baseball especially, we're just in this velocity era. So it's a combination of velocity, volume. Kids are just throwing too much, too often. They're not putting the ball down ever. They're literally throwing all year. And then, especially as they get older too, and they start to work on different pitches in their arsenal, the spin rate is something that they're really dialed in on right now in baseball. Yeah. And to get that spin in the baseball, you really have to squeeze the ball to create that spin. And what that does is it irritates those flexor muscles and the pronator muscles, which are often implicated in this injury.
Right, because of where they attach to the medial condyle, and the attachment's near the elbow. So that makes sense. Let's go ahead and pull up picture 4. So we're talking about the pitching phases here, and maybe you want to comment on this. This is just a breakdown of the normal pitching motion, the wind-up, the early to late cocking phase, acceleration, deceleration, and follow-through. And maybe talk about, what's going on at the elbow throughout these phases, and maybe highlight where the most that valgus stress is placed on the elbow.
Yeah, the late cocking, the acceleration phase is when the UCL is stressed the most, where you get that medial side like gapping of the joint.
Yeah.
And it's just that repetitively over time, what happens is that basically the ligament gets looser and it gets thicker, which leads to some of these problems later on.
Yeah. So it can be ligamentous, it can be growth plate affected, it could be tendons, musculotendinous issue with where those forearm flexor muscles attach.
Right.
So it's kind of heterogeneous, right? Like the what's going on can be variable from
it
one
can be a continuum
child.
Too. Yeah, it can start off something very minor, and if you don't address it, evolve into something much more serious, which would be operative.
Yeah. So. Okay. All right. So let's talk a little bit more about pitching mechanics. Let's pull up that next picture. I believe we're on to picture 4 now, or 5? Yeah, so poor pitching mechanics obviously can contribute to increased valgus stress or medial stress on the inside of the elbow during throwing. You know, and I hear a lot about, you know, a late arm, the arm coming through late, and it coming through late because the trunk is rotating through early. And really, you know, you think about pitching, you're uncoiling the body, right? It's like you're trying to transfer the force from the ground up through the pelvis. That pelvis should open up first, and then using the core musculature, you know, those obliques, you're going to rotate the spine and come through, and then that's going to help to whip the arm around. But can you maybe comment on how this late arm, early trunk rotation, and then you see that if we look at, I can't remember who that pitcher is for the Giants.
Tim Lincecum.
Yeah, Tim Lincecum. You see that he's got a lot of contralateral tilt. And I say contralateral meaning away from his throwing arm. His trunk is tilted toward the glove side.
Yeah, you really do want that trunk to be more vertical.
Right.
Not that tilted to the side.
Right. Now, I will say it does help with velocity for those major league pitchers, a little bit of that tilt, but it also, the trade-off is it's placing a lot of medial stress on the elbow. Now, of course, we're talking right here about little league elbow, which affects young kids, prepubescent youth, and we'll talk about the difference between little league elbow and ulnar collateral ligament injuries, which affect the mature, older pitchers. But yeah, I mean, how would you recommend if you saw a youth athlete, obviously youth athletes aren't shown here, a youth pitcher that was showing some of these mechanics, like what would you do working with them to correct that? Is there any tips that you would give here in this phase?
There's lots of stuff. So one of the things we look at is that hip-shoulder separation. So that we know that correlates to trunk rotation and velocity.
Can you kind of talk about what that is for people that might not understand? They hear hip-shoulder separation. What does that mean?
So you kind of see it in that picture there that, you know, if you don't have the requisite hip mobility to, because ideally you're around 85% or so of your height with your pitching stride. So if you don't have the flexibility of the hips to do that, because as you plant the leg and as the pelvis rotates and as you have the rotation in your thoracic spine, that's where that hip-shoulder separation comes in. And if you lengthen the trunk, you store up all that elastic energy that allows you to come through with your throwing velocity. So, the hip-shoulder separation is really important. Thoracic spine rotation is important. Thoracic extension is important because rotation and extension work together. And so I mean, those are two really, really big ones to help out with the adolescent pitcher, things that I would address right away. So that stride length, that hip-shoulder separation would be two big ones. Yeah,
and I think maybe another coaching cue you might give is to prevent that early trunk rotation and opening the shoulders up. And you'll see this in kids with the early trunk rotation, they really kind of pull the glove towards the opposite side of the body. And then that's going to obviously open up. You know, you're going to start to have early thoracic spine and lumbar spine rotation. And then now you're getting that increased stress on the elbow.
They talk, too, about the open versus closed position as they land. You know, if you look at that picture of Tim Lincecum there, like his foot's, you know, pointed in just a little bit. But if his foot was turned in, that's kind of a closed position where now he takes his hips out of it. Now he completely has to rely on his arms. Whereas if his foot was more open, so if we saw more of the inside of his foot or his foot's turned out, the plant foot, if it's turned out, that's what they call more of an open position. And what that does is it opens too early and that arm is lagging behind, so you put even more stress on the medial elbow, right? So that's why you want to be, as they land, you want the foot turned in just a little bit, like about 10, 20 degrees or so, to optimize those mechanics.
Yeah. And then if you look at, I guess, that middle picture, the inverted W, I mean, that looks good because that pitcher's lead shoulder, it hasn't opened up his shoulders yet. But if you look at, like, his right, so the leg that he's driving off the rubber, the pitching mound with, that right, like, anterior superior iliac spine or the right side of the pelvic girdle, it's starting to rotate, which is good, but he hasn't started to rotate his lumbar spine, thoracic spine towards the plate.
And his arm's lagging behind. You really want to. What we try to tell kids is to try and get this kind of this inverted L, or this this L position as they come out of their glove. You'd rather not be down and then back up, because that can again create trouble at the shoulder.
Right.
Which is a whole different injury. But ideally, like I said, they come out of their glove and they're right up in this L position.
Right in that arm slot. Yeah. So that's a little off there on the inverted W. But as far as if we're looking at his pelvis and his trunk rotation, that looks pretty good there in your opinion.
Yeah, because as you plant, then that's when the rotation would start. So ideally, when you plant, you're in that L position, and then again, as you plant, you rotate the pelvis, rotate the trunk, and then the arm comes through.
Yeah, and I know, you talked about mobility, like you said, through the T-spine. It seems like so many people have poor thoracic spine rotation and mobility, and then also hip mobility. And so that rear leg, if you're a right-handed pitcher, you're driving off that rear leg. You've got to have adequate external and internal rotation in that hip, because I know to start the pitching motion as you wind up, that rear hip is going to externally rotate, but then you're going to move into internal rotation like you see with Tim Lincecum in his drive leg. He's basically moved into internal rotation on both the plant leg and that rear leg. And then what would you say about, having adequate, it's very important, adequate lower body strength and power to save from upper extremity issues. So adequate, strength, strong, powerful hip extension, knee extension, and ankle extension as well.
Over half of the velocity of the pitch comes from the legs and trunk. All it is force transfer. And frankly, I don't want to pick on Tim Lincecum. He was great when he pitched, but he didn't have very much longevity. Look at those skinny legs. Chris Sale's another one that comes to mind. Could throw smoke, but not very big, strong legs. Think of a guy like Bartolo Colon. He's been around, since dirt, and he's done at a high level for a really long time. Bigger guy, David Wells, another one.
Yeah.
Nolan Ryan, the guys that stuck around for a while. Even Roger Clemens, I know there was some suspicions around, performance-enhancing substances.
Drugs,
but prior to all that, Roger Clemens had big tree trunk legs. I'm not saying it's a requirement, but it certainly, it doesn't hurt, because not only does it generate the force, but it dissipates it too.
Yeah, and I know, like Coach Joseph Potts, who I've had on out at Top Speed Strength and Conditioning, he's talked to me. We've talked a lot about, he does a lot of plyometric training with his athletes, really trying to develop explosive athletes, including working with pitchers. And we were talking one day, like over lunch, about the importance of plyometric training and lower body strength in pitchers, and how much, like you said, that really improves the velocity on the pitch and can kind of safeguard that shoulder and elbow. If the lower extremity is strong, the hips are mobile, you have good spine mobility. There's just so many moving parts here. Because like I said, it's a kinetic chain. So you're putting force into the ground, there's ground reaction forces back up through the body, and you're transferring that all the way out through that acceleration and the pitch release through the arm and onto the ball. So a lot of moving parts there in that chain.
Well, and that's why it's so important, not only from a rehab but training perspective, that you work on proximal hip strength, you work on rotator cuff and scapular muscle strength, anterior shoulder mobility. We talk about the layback, in pitchers. I'm a lefty, so I don't know if you'll be able to see it with the camera, but, that arm getting back. Well, if you don't have the mobility in the shoulder, you don't have the external rotation of the shoulder, you don't have the thoracic extension and rotation, you're going to have to generate that layback yourself, which further cranks on the shoulder and further creates gapping at that medial elbow. So and that's the thing nowadays, is that kids, all they're doing is working on the sport and the technical side. They're not building their athleticism through getting stronger legs, the mobility that we talked about in the hips, the mobility in the thoracic spine, the mobility in the chest wall, working on cuff and rotator, or cuff and scapular strength. It's definitely a combination of things that. Right,
that's an overlooked part. You're exactly right. It's like they have the sports skills and they're working on that constantly. And if you're working on it constantly, then you're at risk of overuse injuries. But they're not doing the year-round, like, strength and conditioning and keeping their body physically prepared and getting adequate rest and all those other factors. They just get overlooked. All right, anything else before we move on? You want to comment on?
That's a good start, I think.
Okay. Well, let's go to the next question then. Who is most susceptible to Little League elbow?
I would say really any young athlete with open growth plates that's throwing too much, and probably thrown with that higher velocity. What tends to happen is you get a kid that's maybe growing up a little, maybe he's a little bit ahead of his peers on height and size, so he's throwing a little harder, so naturally you use him more, right? Mm-hmm. So we're basically using his bullets. So that's problematic. But also too, there's some decent literature showing that the weighted ball programs are potentially a problem for these kids, especially with open growth plates. So and maybe that's something we talk about later, but that's not helping.
You can talk
either.
about it now. So what's going on with the weighted ball program?
Yeah, it's quite a hotly contested topic. There's a lot of marketing and a lot of secondary gain with trying to sell programs and things like that. But there's been some literature showing that the increase in injury with those. We're not quite sure how to dose them yet. I tend to say that the literature is clear that it does increase shoulder external rotation to use them. It does increase velocity. But I would really, really encourage people to wait to use those until they're skeletally mature. Yeah. And I tell parents, anybody that'll listen to me.
What type of weight are we talking about with the?
Well, that's what I said. Are you doing underweight balls? Are you doing overweight balls? That's what I said. And that's a whole other discussion. But what I tell parents and anybody that's willing to listen, that you got to earn the right to use weighted balls. You got to do all the other stuff we were just talking about first. Like you can put weighted balls in your hand, that's fine. But if your hip shoulder separation is terrible, if your hip strength is awful, you don't have the requisite shoulder range of motion, all those other little things. You got to check all those boxes first, before you even think about doing those things. You know what I mean? So, like I said, that's a whole other discussion. But I'm not in favor of them in young athletes that are skeletally immature. If you're a college athlete who's maybe needs that extra mile or two, maybe 3 miles an hour to get to that next level, but even then I would encourage that athlete too to make sure they've checked those boxes. Right. Are they doing the leg strengthening, the hip mobility stuff, the thoracic spine stuff, all the things I talked about previously? Right. They need to be doing those things too before they just throw a weighted ball in their hands, right? Right. So.
As we would say in Western Kansas, because I'm from Dodge City, don't put the cart before the horse, right?
Right. Well, right.
So, all right. I was trying to remember if there's anything else. So, and like you said, with the growth plate, and this is why, those prepubescent adolescents, you're looking at, ages 8 to 14, anywhere in that range that tend to be most susceptible. It's important for people to know that those growth plates at the end of the long bones, these are composed of cartilage. And as you're growing, childhood into adolescence, this is where the bones grow in length. So there's chondrocytes there. These are cartilage cells. And they kind of provide like the foundation for the osteoblasts to come in and build bone. And this process is going to continue. You're going to continue adding bone in layers, and the bones get longer until that cartilage, that growth plate, closes off and it becomes completely ossified. And it doesn't become ossified until really like the influence of testosterone and estrogen. Those hormones close off that growth plate, and then the bone's no longer going to grow in length. And typically that happens around maybe 18, like in a male, 18 to 20.
16 to 18 in a male. Girls are mostly done around 14 for the most part.
Girls, it's earlier. But it's the influence of those hormones that are going to finally basically prevent, I think there's actually apoptosis of the chondrocytes that occur. So those chondrocytes there's no more cartilage there, and then that cartilage plate, that epiphyseal plate or growth plate, just becomes fully ossified. It's just mineralized. It's composed of bone. And then from that point on, the bones can only grow in thickness, like let's say if you were strength training, but they're not going to grow in length anymore. So,
and it's important right now, this is a good time to talk about like where those injuries happen, youth, skeletally immature versus skeletally mature. If you have young athletes, they tend to, their ligaments are stronger in the mid-substance. Like young athletes don't tear mid-substance. As the ligaments on its periphery, that's when it's weakest, and the bone's softest until they ossify. So that's why you're seeing kids, they take the ligament and the bone together. That's the apophysitis piece, okay? And they don't tend to pull the ligament from the bone, whereas adults or skeletally mature athletes, they tend to either tear mid-substance, which kids don't, mid-ligament, or they pull the ligament from the bone. Adults tend not to, because their bones are fused. They're not as soft as adolescent athletes are. They, like I said, they pull from, the ligament pulls away from the bone, not the bone and ligament together like they do in the skeletally mature athlete.
That's a good point. Yeah, that makes a lot of sense. So we'll move on to the next one. If a child is obviously complaining of pain, what are the signs and symptoms of Little League elbow? And Gosh, I can remember back when I was a kid. I think I was 10 years old playing in a tournament in Larned, Kansas. And we were in the losers bracket. And you know what happens? That next day, you're playing game after game. I think we played like 5 games that next day. And we came all the way back and got 3rd place. I still remember that medal. It's one of the medals I was like, as a kid, most proud of, because we had to fight our way back just to get a 3rd place medal.
Not just for participation?
Right, all right. No participation trophies here, right? You got to earn that medal or that trophy. And we earned it. And gosh, I can remember eating hot dogs in the dugout between games, and Dad's coach was like, hurry up, you guys got to eat. I'm getting the lineup ready for the next game. Like, we got to go. Here, eat your fruit, eat your hot dogs, whatever. We're getting back on the field, just covered in dirt and everything. It was a great time. But I know, and my dad admitted, I had pitched on a couple consecutive days, not good, and I was having horrible medial elbow pain. But I know he kept pitching me because for some reason I kept throwing strikes and was getting batters out. My velocity wasn't that good the next day or whatever. It was several days in a row that I'd pitched. And I just remember at one point I couldn't even lift. Like, the inside of my elbow hurt so bad I was struggling to even lift like a water bottle. And
look, I mean, your velocity,
right?
Too much volume, right?
Yep.
I mean, it's just a recipe for disaster, for a young elbow. Usually what happens is when kids are struggling, that you'll see them start to kind of shake their arm out, or they'll start to rub their elbow, they'll start to kind of move it like this, hoping that just moving it the right way will take the pain away. But yeah, you're right. I mean, a decrease in velocity, and usually the pain just tends to increase the more you throw. Like, it goes from, it shows up late in the game or later innings. Now it's showing up earlier. Now it's showing up in warm-ups.
Right.
Or the severity is even worse, right? And that's where you start to see that you really got to pay attention to that. Don't let those things fester. Yeah,
coaches, pay attention to your athletes when they're on the mound, their body language, what they're doing. Are they, like you said, shaking the arm out? Are they rubbing it, acting different? Ask them. And don't let them work through that elbow pain. I mean, I know we had talks about afterwards. My dad was like, I shouldn't have done that. I should have taken you out. But it was, batters were striking out. We were winning games. And then it was like, and I was stubborn too. I'm like, well, no, I'm fine. You know how it is. If you're a competitive athlete, I'm good. I can work through it. And
that was really before the days too, where we knew about pitch counts and stuff. And, now we know too that not only, actual game pitches, but we have to do the total workload. Like, what's their warm-up pitches and what's their bullpens, like all that stuff and we're still learning about that. Like, what is there a target number? And even then, you can't have a target number because of skeletal maturity, years of experience, all those other things that go into it. But we now know that we have to count those pitches too.
Right. And you're right. And this was before, because I would have been in like the early 90s when I'm talking about my story when I was 10. But so the pitch counts, those things weren't as big of a deal. And it was always, I think we were going to talk about this later, but the big thing back then was like, don't throw curveballs or don't throw breaking balls, until you reach skeletal maturity. But you want to comment on anything where's the status of things with younger athletes, say a 10-year-old throwing a curveball or a slider?
I always encourage people, let's get that fastball squared away. Like the location and stuff. It's well known. Like, Greg Maddux is a guy that was in the high 80s, low 90s most of his career, but he could throw a fastball through a Fruit Loop.
Locate it.
Yeah, and it said work on that piece.
You're hitting the black of the plate on the outside.
Being able to locate your pitches. That's the thing. Right now we're in a throwing era versus a pitching era, right? Like, guys used to pitch. Right? Like, really work on location. If you could do both, that's great. But sometimes you sacrifice one for the other. And, so I encourage, if you're an older kid, or if you're, just getting going, like a fastball and a changeup or two that I would master first before we worry about breaking pitches. I know that's what everybody talks about. I know they're much more sexy to throw, whether it's a sweeper or a slider or a curveball or whatever the case may be. But, in my opinion, it should be fastball, changeup first. Get those down pat, and then maybe you can do that later. There hasn't been a whole lot of research showing that the curveball is the problem. Yes, there's a little more gripping, a little more torque at the elbow when you throw a curve, but we're now knowing that that's not the problem. It's, again, velocity and volume.
Okay.
And that spin stuff, if you're into that. I mean, those three are the three-headed monster of medial elbow trouble.
Velocity, volume, and spin rate.
Yep.
Yeah. Okay. All right, so we got through the signs, symptoms. Like I said, elbow pain and swelling, that's obviously going to be the big one. An elbow that feels stiff, maybe difficulty extending the elbow. And then, of course, loss of velocity, that's going to be a big one. You see the kid, obviously you're hurting, you're not going to throw as hard. So Next question. So, how can Little League elbow be prevented?
A number of ways. Again, as I highlighted earlier, we want to monitor those pitch counts, monitor those. And you might be saying, well, what number is that? We don't really know that yet, but we have to count them, I guess is my point, right? So it's effort and intent. It's throwing on a line. It's not necessarily, a crow hop, a little hop, and like a lob throw. We're talking about literally throwing with high intent on a straight line. Like that's a problem. We know that throwing beyond 120 feet has more stress to the medial elbow. So a lot of these long toss programs, you're throwing 180, 300 feet. Bad idea. But a problem is baseball, especially the higher you get up, the more it's very popular, these pull downs and these long toss programs, right? And those distances that I mentioned beyond 120 feet are much more stress to the elbow. I would stop doing it. You throw 60 feet 6 inches. Why do you necessarily have to throw that far? Now some guys are used to it in their program. If you do that, maybe just reduce the volume of those long toss throws. So that's one. The other one is again, just working on that athleticism. You've got to do the other things, the strengthen the hips, the thoracic mobility, the chest wall mobility. Make sure your shoulder range of motion is right. Rotator cuff strengthening, scapular strengthening. Play other sports, right?
Yeah.
That's a big one.
And the early specialization, we could go on that tangent right here
with
too.
Throwing specifically, if we throw more than 8 months a year, your risk goes up 5 times to get injured. So put the balls down.
At least 4 months. At least 4 months out of the year, put the balls down.
And there's an interesting stat. I don't remember. The numbers are escaping me, but there was a heat map that was published a few years ago, basically of the 200 game winners in Major League Baseball. Overwhelming majority of them were in northeastern states. And why is that? Because of snow.
It's cold.
It's cold. You got to go inside. But again, everybody's inside at their throwing academies now. And it's like, go play basketball.
Right.
Even the big leaguers put the ball down for a little bit. You've got to let that elbow heal. And we do know that if you stop throwing, remember I mentioned before, if you throw, the more you throw, the UCL gets loose and thicker. But if you put the ball down, it actually tightens up and thins out what it's supposed to be, right? So I mean, there are changes that occur if you just stop throwing. And anybody will tell you that works in high-level baseball. These kids are, the exponential increase in Tommy John since the year 2000 in high schoolers and minor league players has skyrocketed.
Yeah, we're going to talk about Tommy John.
Yeah, we are. We're going to get there, but I'm just saying that's what it leads to. And these guys are getting to these levels, and their elbows are trash.
Yeah.
And a lot of it's because of what they did when they were a kid. They threw too much. The showcases. Don't play in multiple showcases throughout the summer. That's another one.
Yeah.
I mean, there's so many factors. It's hard to even talk about them. But yeah, watch the showcase ball. Don't pitch and catch in the same game. That's another one. So if you pitch and let's say you get pulled after a few innings or what have you, go play middle infield.
Right. Yeah. Because then if you're down playing catcher, now you're throwing down to second base, and you're
and pitchers are the bell of the ball, but we got to talk about catchers too.
Yeah.
They have an extremely high volume. They have a lot of higher intent, right? And they often will do they'll pitch or they'll catch multiple games per week, right?
Yeah.
Pitchers usually get a few days rest, starting pitchers anyway.
Yeah.
Not catchers.
Yeah.
Right. So I mean, we have to think about them too. So that's why I said there's a lot of factors at play here.
Right. And then I guess obviously other prevention, coaches, it's important for you to teach proper pitching mechanics. We talked about some of this, avoiding that late arm coming through and the early trunk rotation and the excessive trunk tilt. They shouldn't be tilting their trunk away from the throwing arm excessively. So again, look for those things if you're coaching pitching mechanics.
I would say also as a side note here, sorry to interrupt, go to the American Sports Medicine Institute website, asmi.org. They do a pretty good job of pitching mechanics there, and they have a checklist and stuff that you can go through as a coach and things if you decided to want to film or record your pitchers to help them work on some of these things.
Can you say that website again? That'd be good for everybody.
ASMI.org, American Sports Medicine Institute. It's down in Birmingham, Alabama. Some of the best minds in biomechanics and baseball have worked on that and have done some really good work and a great service to the baseball community.
All right, that's great. Thanks for that info, Dr. Lorenz. Let's pull up picture 6 here. So we mentioned a little bit about pitch counts and pitch limits. So these are, based on age, it's kind of hard to see. Just some guidelines. I think these were from USA Baseball.
Yeah.
I mean, how do you feel about these guidelines for the different age groups? Do you agree with it? Do you think it's reasonable? I mean,
again, these are fine. It's a good starting point. It gives somebody something to reference. Usually, the older you get, the more pitches that they'll allow. But again, the key, though, we now know it's not just in-game pitches; it's the total workload.
right.
So, if they're throwing bullpens, if they're throwing with intent at practice, like we just count the pitching ones. But if you're throwing live BP at practice twice a week, in addition to your game pitches,
That's got to be factored in. You got to think
right?
of that.
So, so we now know that it's total workload, not just your game pitches.
The arm doesn't care if you're on the mound pitching in a live game, or you're pitching in the bullpen, you're throwing batting practice. It's still the arm working. Yeah, it's cumulative overload, like you said. Yeah, yeah. All right, so let's talk about how is Little League elbow diagnosed. We can pull up picture 7 here. Maybe talk about this image.
You see that separation of the medial epicondyle from the humerus there. Oftentimes, they might do what they call a stress radiograph, where there's a weight in the hand, and what that does is it can gap the medial side of the joint where you see that. Again, typically the X-rays would, when this is clear case of apophysitis, they normally might do an MRI in addition to that, just to see if there's any other associated soft tissue damage.
Yeah.
But X-ray is always the first spot that they'll go, and then if need be, they'll get an MRI.
Yep. All righty. And then let's talk a little bit about treatment. How do we get over this? Young athlete suffering with Little League elbow.
Rest and activity modification. Usually one of the, again, I talk to kids about kind of where they're at in their season. If we got one more tournament we got to get through, okay, let's muscle through that tournament and let's put the ball down. Let's get you better. Sometimes it is just changing positions. Okay, I don't want you to pitch, but you can play second base. You can DH. You can play can you play first base? Like something else, right? Maybe it's just not pitching as much, right? I would say, are you playing in multiple leagues? Are you doing showcases? Again, something's got to give. Like, this does not just get better, but there has to be some degree of relative rest. And that's where a challenge as a sports PT, that you want the kids want to play. Your job is to do what you can to keep them as free from injury as possible, but also keep them on the field. And that's any athlete, whether it's a runner, a swimmer, doesn't matter. They want to do their sport. So it's talking to the kids about manipulating those variables, about watching the tournaments and the showcases. But then if I can get them to put the ball down a bit, or at least reduce their throwing volume, then we work on all those things we talked about: leg strengthening, hip mobility, thoracic spine mobility, shoulder mobility, and then cuff and scapular strengthening, and if need be, mechanics.
Yeah. Yeah, and I love how you point out this relationship between intensity and volume, because that goes for so many things in different sports. Whether you're a runner, you're thinking about, well, I can, run at a higher heart rate, but you generally cut the volume back, or I can run at a lower heart rate. You can run for longer. I mean, whether it's lifting in the gym, well, I can lift heavier loads if I'm in season, but I better cut the volume back, right? Because I don't want to get into overreaching or overtraining. And then the same thing with other sports skills like throwing. It's like, if you're going to be doing a bunch of long tosses, well, you don't need to do as many reps. Cut the reps back, because that's very intense. If you're going to be, just pitching from Little League different distances, obviously different, 45 feet, different than Major League.
Right.
But it's like, still, that's a shorter distance. You can maybe do more throwing, but still you have to be aware of this. Yeah, it's a shorter distance. You can maybe do a little more volume, but the intent and the intensity, that all has to be factored in. And there's always should be this inverse relationship between intensity, the distance, the speed that you're throwing, and the total number of throws.
Right.
I mean, that's so key.
Throwing on flat ground on a line with high intent is really problematic for the medial elbow. Like, it's even better to be on a mound, because you got that downward, that helping you going downhill, right? So it's actually better to throw from the mound rather than flat ground, right? But it's still, it's volume, it's intensity, the distance matters too. Like I said, 120 feet is really that cutoff where you start to, the medial elbow forces increase exponentially after that distance. After
120 feet, okay. That's important notes to remember. All right. So how long with rest? Like, if you are going to tell an athlete, like, you need to rest, what's their question? Now, I know we kind of all heal different. There's different, even like we've talked about in rehab before with different injuries, like you're trying to hit people always want to know timelines, but you're trying to hit specific goals like in rehab from certain. But an approximation. I mean, you're going to say how long you have to rest.
If you have a bony involvement like in that X-ray, I mean, you're probably going to be shut down for at least 6 to 8 weeks because that bone's got to heal, and it takes time for that to heal. Because the next step is if it doesn't, they're going to put a pin in it.
Yeah.
And now you're out for a really long time.
Yeah.
So that's why I said it's kind of one of those ones where you can take my advice or you can choose not to.
Right.
But again, it's sometimes where are we at in the season? How big of a deal is this kid? All those things matter. What level are they? Is this? There's a lot of factors at play here. But I mean, you're looking at, like I said, again, depending on severity, how long they've had symptoms, all of those things. You're looking at probably at least 4 weeks. But it could be up to 3 months, depending on how bad it is.
You know of any cases or worked with any young athletes where because most of the time you don't need to have a surgical intervention, but have you some cases where they didn't rest, they didn't take some time off, didn't put the ball down, and actually had to have surgery?
Oh, tons. I mean, I didn't play in that other showcase. Well, you're still playing too much. You know what I mean?
Right.
Like there's something. You gave a little, but not enough, right? Like we warned you about this, right? That this could happen. So,
what's the youngest athlete? I'm just curious now. Like my gears are kind of turning. Like where you've seen, oh my gosh, they didn't put the ball down, they didn't stop, and they had to have surgery.
No, I haven't seen them myself, but I know colleagues that have had kids with like Tommy John at 10, 11 years old.
Oh my gosh.
And the apophysitis one. I've certainly seen plenty of those in 11, 12 years old where they have to put a pin in their elbow. So I have seen those, and again, that's just really, really sad because that's coaching and parenting fails right there. That's all that it really is. I mean, that's what that is for the most part.
Yeah. All right. So, Dr. Lorenz, let's move the discussion to talking about ulnar collateral ligament or UCL injuries. This is again a structure on the medial or inside aspect of the elbow. What causes sprains or tears of the ulnar collateral ligament? We can pull up picture 8 here.
It's really the same thing. It's the volume, it's the velocity, but things contribute to it too. If you don't have that thoracic mobility, that front shoulder or that anterior shoulder, chest wall mobility, those kind of things, if you're not getting that force transfer. But by and large, like I said earlier, I keep saying it, but it's so important to get it for this particular injury, whether it's Little League elbow or UCL, tears and partial tears, things like that. It's velocity, it's volume, and it's spin rate.
Yeah, okay, very simple. And of course, there's different parts of the ulnar collateral ligament. This is just kind of a generic image showing, where it is and damage to it. But, any comments on?
So one thing with this injury, with UCL injuries, it's the location of the tear matters. The proximal part of the ligament has a much broader attachment, and that's where the blood supply is. The distal part that attaches on the ulna has a much thinner attachment site.
So proximal is near the humerus, just to get our terms down, near the humerus.
Right.
Distal is down near the forearm.
Thank you for that, yeah. But the distal part doesn't have the blood flow that the proximal does, and it has a narrower attachment. So it's not able to spread those forces out as much as the proximal piece. So what I mean by that is that tear location is a big deal with this, if you can manage this with or without surgery, right? So, Dr. Keith Meester, who I hope I said his name right, is a team physician for the Texas Rangers, and he's talked a lot about, the 5 Ps of this tear, and it's, he talks about like the player level. So is this high school, college, is this a young kid? What's their potential? Like, what's the realistic upside to this kid? Is he really going to be a major league pitcher, or is he just living the dream till the end of high school, right? The timing, he calls it periodality. So when in the season is it, right?
Yeah, beginning, mid, end of the season.
And also the location of it, right? So, that, is it a proximal, is it a distal tear? And then the position. This injury, a partial ligament tear, proximal up by the humerus, in a middle infielder, you got a much better chance to rehab that than you do in a starting pitcher with a distal partial tear, right? Because I mentioned earlier about the healing potential, and your risk of going into surgery with a distal tear is much higher than it is with a proximal. Like, it's 12 times more. Like, it's significant difference if you have a distal versus a proximal tear.
Yeah, that's interesting. Like you said, it all matters where, because there's differences in blood supply to the proximal and distal parts. So it's like, you have better blood supply. Well, guess what? More nutrients, more oxygen. that tissue, that part of the ligament's going to be more likely to heal on its own. And I'm sure you get that question like, hey, Dr. Lorenz, will this heal on my own, or am I going to have to, have surgery?
Again, sometimes, but how long you want to put the ball down for?
Right.
You know what I'm saying? Like that's a problem, right? Because they need to be better yesterday, right?
You got to be a parent. Take the ball away. Give me your ball.
That does matter. Like, and that's why timing matters.
Yep.
Because if the season's done, it's like, well, maybe you should sit out fall ball so you're ready for spring.
Yeah.
And that's where, again, the upside piece is this senior year, or is this a kid that's really got a legit future? Because if that's the case, you want to try and avoid that surgery. So again, something's got to give.
Yeah, I know. I got a buddy, chiropractor, Jesse Grove, out in Dodge City, and has a clinic in Great Bend, and we talk a lot. And he makes his kids. There. Yeah, hey, you need some chiropractic treatment, go see him. But he makes his kids, JJ and Gage, they're both high school baseball players, and he talks a lot about I make them set the ball down, and even. Obviously, to save the elbow and the shoulder and all that, like taking time off is important. But he's like, it keeps them hungry too, psychologically. Like they start wanting to throw again after having to set the ball down for several months. It's like, okay, I'm ready to be out there again and tossing that ball around. Yeah. And so, it keeps you hungry, because I do feel a lot of times in young kids that maybe specialize in a sport early, there's that risk of burnout too, where it's like just psychologically. But yeah, so rest. You're hearing it over and over and over. Common theme. Set the ball down. Let's move on to kind of explaining the difference. I mean, we have some here, but what's the difference between a UCL sprain or tear and Little League elbow? And then we defined who was most susceptible to suffering Little League elbow, youth that have their growth plates have not closed yet. So who's susceptible to suffering the UCL injury, and what's the difference?
I mean, usually it's just skeleton mature versus not. I mean, certainly the ligament is implicated a little bit, as you avulse the medial epicondyle away there as we saw in those earlier images. Plus, both of them get muscle inflammation of the flexor pronator mass. Like when you see on, if you ever watch ESPN or something, and you see on the bottom line that so and so is sitting because of flexor pronator tendonitis, like holy moly, like that's like the storm's coming, right? Like the skies, you hear the rumble of thunder and the skies turning gray.
Can you explain what that is, flexor pronator tendonitis?
Yeah, sure. It's so on the medial elbow, you have your flexor and pronator muscles attach on that medial side. And again, because of the gripping, the pitchers talk a lot about, the sticky stuff they use to help them with the grip. But as they've gotten rid of that, guys sweat, they have to grip the ball harder. So what that does is they're constantly,
more force of
they're constantly gripping that flexor pronator mass, which can irritate, and it's a protector to the elbow. So if that gets irritated, now that elbow is allowed to gap open further, right? Because that flexor pronator mass decelerates opening of it, right? So that's why it's so important that we monitor that too. That's why doing flexor pronator strengthening is part of, again, your treatment. I mentioned earlier about stuff to do. I forgot to even mention that. Like, it's such a critical part of doing flexor pronator strengthening to help protect that medial side of the elbow.
Strengthen the forearm musculature, because if it's not strong and conditioned, well, then guess what takes the tensile stress? the
ligament. Yeah, the ligament is tiny. You see how tiny that little ligament is. I mean, it's just, the baseball pitch is like the fastest motion recorded. It's like 7,000 degrees per second. Tennis, I think, is like around 1,200. Just throwing a baseball normally, at from short to first, is around like 5,000. You know what I mean? Yeah. So it's that's a lot. Whereas like underhand softball throw is like 700 degrees per second. So it's massive, massive. Yeah.
And overhead throwing is just not a natural motion.
No,
an underhand softball throw is more natural because of the way your arms swing than an overhead throw, for sure.
Right. So it's a high velocity, tiny little ligament, and lots of little things that go into why it gets irritated.
Yeah, and you mentioned the strengthening of the forearm musculature and conditioning of that, and you said, well, we kind of haven't even talked about that. Anything else you want to add? I mean, I know, like you said, the hip mobility, T-spine extension and rotation, that's all important. Scapular strengthening, all those muscles that attach to the scapula, the stratus anterior, the rhomboids, the lower traps. I mean, you think of all these muscles kind of in the upper and mid back that control that shoulder blade and the throwing motion, the rotator cuff. I think often overlooked with the rotator cuff, the external rotators, infraspinatus, teres minor, strengthening of those, because they're going to actually help decelerate the arm as you follow
Yeah,
through.
we have plenty of gas. We have plenty of gas, but no brakes. So we got to work on the brakes, right?
That's a great way of putting it.
Yeah, I mean, and your brakes are in back. I would say the other two factors.
And you think about how people train. What do guys do in the gym and pick on guys? Like, train the chest, train the internal rotators.
Chest and arms.
And everything is pressing and internal rotation, right? Overhead pressing, it's all pressing and internal rotation and extending the elbow. So yeah, your chest is strong, the internal rotators are strong, the triceps are strong. Those are all important for the gas, like you said. But those decelerators on the backside of the shoulder that attach to the scapula, the infraspinatus teres minor, those are so often overlooked.
The other two that are a big deal for this injury as well is shoulder flexion loss. Like there is a significant relationship between shoulder flexion range of motion loss and medial elbow trouble. And the reason why that is that as they accelerate through in their deceleration phase, the lats, the latissimus dorsi is often an accessory muscle for deceleration of the arm. So there can be some contractures there that limits shoulder flexion. And then the other one that's really important that we look at too is total range of motion of the shoulder. Okay, so as I have my external rotation plus my internal rotation, usually that's around ER plus IR is around 180 or so. But you compare it to their other side. We know now that like throwers have a structural adaptation to throwing repetitively.
Yeah,
so
this is getting into like glenohumeral internal rotation deficit, which doesn't necessarily mean it's a bad thing.
No,
it could be.
It's what I'm saying. Like usually what you see is that so if I'm a thrower and I have a external rotation gain of 20 degrees compared to the other side, but I should also have an associated loss of internal.
Right.
Compared to the other side. So what we look at with that is that
it's
you mentioned
the total.
Yeah. You mentioned glenohumeral internal rotation deficit. So there's a difference between anatomic GERD and pathologic GERD. So anatomic GERD is, I've got my extra 20 here and then I lost 20 here. That's the anatomic. The pathological piece is that I've lost total. So there is a difference in total side to side. But there's also an associated loss of internal rotation. Depending on what paper you read, it's as low as 5 degrees. I think that could be measurement error. That's probably not enough to get excited about.
Right.
But I would probably start being concerned around 15 degrees or so is where I would really start to try and address that. So certainly, again, that's another piece of this. It's the shoulder flexion and then the rotational or the total range of motion.
Right. It's all, proper shoulder mobility important for elbow health. Yeah. So many parts here in the chain that are important to address and think about. All right, so where are we at here? Let's just talk about signs and symptoms, again, of a UCL sprain or tear. I mean,
it's largely the same as with kids. You get that medial pain with throwing. It's typically with throwing. Sometimes the kids will say that you grab a backpack or something, like they grab a heavy bag or something. They pick up the bar at the gym doing trap bar deadlift and they get quick pain just because, again, it's like that stress radiograph. They grab weight and it pulls and it gaps that elbow. Yeah. So things like that can be problematic for them. So usually it's the pain increases the more you do. Like it shows up earlier and it shows up with less intense throws. Usually these kind of things start where they hurt late in the game from overuse, but then the more you try and work through it, it's hurting earlier, and now it's hurting in warm-ups, and those kind of things. So, and it snowballs the more you do.
And there's different grades of the injury. We'll bring this up and talk about it in a bit, but like obviously if it's a complete tear of the UCL, you're going to hear a pop.
Yeah,
you're going to feel a pop.
Feel a pop or hear a pop. Yeah.
Yeah. So you're not going to be throwing, that's for sure. I mean, you may be able to do certain activities of daily living, but you're not going to be doing some high velocity throwing at that point. Yeah. All right, move on to, again, and some of this is going to be, I know, similar to the Little League elbow, but UCL injury prevention. How can UCL injuries be prevented?
It really is the same thing. Not to be redundant, it's monitoring that total workload, putting the ball down, doing all those things we talked about. You got the leg strengthening, the hip mobility, thoracic mobility, the shoulder range of motion stuff we talked about, rotator cuff and scapular strengthening, rest in the off season. I mean, that's a big one. Play other sports. That'll help a lot.
Yeah.
So, and that's what I said. It's our fault. These kids are going out of high school and into college with already having operations. I mean, it's too much too soon. Yeah. It's the bottom line. It's too much too soon, too fast.
It's unfortunate. Yeah, very unfortunate. So let's talk now about how are UCL injuries diagnosed and classified or graded.
Yeah, I mean, it's the same thing as a medial. They usually do an X-ray first, make sure there's no bony involvement, and then because it's soft tissue, those will definitely get an MRI.
Yeah.
And then that will determine the extent of the tear. Again, you want to know the tear location. Like I said, that's a big deal, how bad it is. And then, like I said, they will often do that. Like I said, that stress radiograph where they put a weight in the arm and it gaps the joint. And they can tell the extent of the separation.
I think they typically use gadolinium. Don't they use contrast quite a bit when they're trying to check the UCL?
They can, yeah.
Yeah,
that's an option.
Get a more clear-cut image. Yeah, and then so the grades of UCL sprain injuries. Do you maybe want to talk about how they're graded 1, 2, 3?
Yeah, I would say grade 1 is typically just a stretch, of it, or like just a general irritation. Whereas a grade 2, you're getting more of some separation of fibers there, maybe some pulling away of the ligament from the bone, and then grade 3 would be a complete separation.
All righty, okay, and then now getting into ulnar collateral ligament injury treatment. You've mentioned that depending on the location, proximal versus distal, and the blood supply, the ligament can, if you had let's say, a grade 1 mild stretching or even a grade 2 where there's maybe some partial tearing, it could potentially heal on its own depending on the location. And then let's talk about the other treatment options. And I know a lot of this depends on, like you said, is this going to be an athlete that may compete at the professional level one day? What position do they play? What are their goals? Maybe comment on some of these other treatments. I mean, obviously, if it's minor, we know NSAIDs, ibuprofen, all that, maybe ice.
So one of the treatments that's there's still a lot of debate about this is PRP injections or platelet-rich plasma. Essentially, what happens there is that they withdraw some of your blood, they spin it down, and they withdraw the platelets basically and kind of inject them into the area.
Right. Those are in the plasma, so you're injecting the plasma.
It's all these healing factors that help.
Yeah, growth factors.
Again, the evidence for that. I mean, we're still kind of figuring out what the recipe for it is. Like, what's the best recipe for the PRP injection? Leukocyte poor, leukocyte rich, and beyond the scope of this discussion, my point is that the data is very mixed on it, and the problem is that they're expensive. They're not covered by insurance. It's out of pocket, so it's very much can you afford it or
experimental.
not? And again, I tell athletes all the time that if you do this and it doesn't work, I mean, because after you have that injection, you've got to pretty much do nothing to let it do its thing. You can't just get the injection and go start pitching. Like, you've got to shut it down, and you go through these 6 to 8 weeks of not doing much, and then you start to throw again, and if it's still problematic, well, you lost all that time. So that's something to think about with that. The other
money.
Well, right. And the other option is if you have a partial tear, there's some real promise with this procedure. It's called an internal brace. Internal bracing is a technique where they're using it in many joints, not just the elbow. But basically what it is, it's a fiber tape that is put, basically, it's put on top of the UCL. And what it is, think of it as a rubber band that's a little stiffer than a rubber band. That's probably the best way to say it. And basically, it acts as a stress shield for the native UCL.
Right.
These do very, very well. You get back to throwing like at about 3 months. Which if you have a full out UCL reconstruction, you're not throwing for more often than not at least 5 6 months. Really throwing. So it certainly shaves the rehab time. It's a great option for, let's say you're an outfielder, middle infielder with a partial tear, and you got a few years left to play. That's a really good option, but if you're a starting pitcher and you got a lot of zeros in your contract, they're probably just going to do the full-on Tommy John because you're going to, again, just because you're going to continue to throw and, it might not hold up as long.
Which, now that you mentioned Tommy John, that leads into the next thing that I want to discuss here. So, Tommy John surgery, Tommy John was a major league pitcher back in the 70s and 80s, but in 1974, the first Tommy John surgery was performed. And it's called Tommy John surgery because that surgery was performed on Tommy John. So let's talk a bit about what occurs with Tommy John surgery and what exactly that is, like what they're doing here. So if we pull up picture 9, so you see Tommy John there on the right actually showing his scar and then him pitching. I think that was probably taken in the 80s there in the Yankees uniform. But again, the first player to have an ulnar collateral reconstruction surgery performed back in 74. So if you maybe just want to comment there on, how this surgery is done, what they're doing to repair the UCL.
So there's various techniques beyond the scope of this discussion, what they do, and I'm not a surgeon anyway, but what they try and do with this, they call it an anatomic reconstruction. If you look at the elbow and the medial side there, and you see that there's 3 branches of the UCL, and you can kind of see them in that picture. And if you look at it, you can kind of visualize, see an 8, right? And they typically will make, it looks like basically the number 8 when they put this graft in. They can take a palmaris longus, it's a tendon in your forearm. They can take hamstring tendons as well. Really, it's kind of the surgeon's preference. They often take the hamstring on the other leg, like the medial hamstring on the other leg. But again, it's surgeon preference. And really, what it is, it's just replacing the native UCL. The problem is that as you know, the elbow is a pretty small joint. They're putting little tunnels in there, and that's why if you have a revision of this, like if your Tommy John fails, your ability to get back is even less because, like I said, there's just not a lot of bone there to work with. So that's really what they do, is that they take that graft, just like they do when they do an ACL reconstruction. They take a graft from somewhere else and put it in there.
Yep. Yeah. And, I'm sure you get asked this question a lot. Athletes wonder, like, well, if I have this, they completely tear their UCL and they go in, they have Tommy John surgery, and they wonder, am I going to be able to throw with the same velocity after surgery as before? Yeah.
So there's been a few studies on this. There is definitely a decline in performance. The return to play on this is anywhere from 75 to 90%, depending on what study you read. Whether or not they get back to that actual level is another discussion, right? Yeah. Like, so you obviously what we want to try and do is get the athlete back to the level they were at before or better. Right. But some don't make it, right? So, that's a big part of this discussion as far as the performance piece. What I want to make sure we talk about, though, too, is that there is this idea that I should just have the surgery because I'll be a better pitcher after it, right? And that's just not the case.
That idea is out there.
A lot of times athletes do improve, because they do this stuff in rehab that they should have been doing before anyway to avoid the surgery in the first place.
So you got this confounding variable. It's like, well, was it really the surgery, or is it just because after the surgery you worked so hard at the rehab and maybe working with the strength and conditioning coach to achieve peak performance, and you weren't focused on those things before you had the UCL tear? Right.
Right. Yeah, usually the career window is a little bit shorter. Usually, again, depending on what paper you read, the performance is down a little bit, like the longevity is cut down a little bit. But obviously there's plenty of athletes at the pro level that have had them and they're fine, right? Yeah. So, but it's just, again, usually that shelf life has been reduced a bit.
Yeah. And then, again, kind of typical rough estimates, how long does recovery take after a UCL injury?
Again, the level really matters here. So, and how many zeros are after your contract, right? So it could be anywhere from a year to 18 months. So it really depends. If you're an elite level pitcher, you're going to do stints in the minors before you get back at the major league level. But again, a lot of it depends on timing of the year, what level you are, how many more years you got left, all those kind of things.
Yeah. Anything else you want to add? I think
no, we covered a lot of it.
We
covered a lot of it. It's a complex injury. It's one that I think can largely be significantly reduced. I'm not saying avoided. It's like ACL stuff. Like, we know we can reduce ACL injuries with prevention programs and stuff, and those kind of things. You're not going to eliminate them entirely, but we can certainly do a heck of a lot better than we're doing now. And we've got to take, as I'm a parent, as parents, as coaches, we've got to put our foot down, with some of this stuff. Like, we are part of the problem by enabling this stuff, enabling the pitching year round. It's freezing cold outside. I'm going to go inside and pitch, and work with my pitching coach and do more pitching and more pitching and more pitching. And it's like, no, go into the weight room, build your athleticism, right? But again, as long as we keep writing those checks to those academies, they're going to keep doing this, right? They have a vested interest in you being in their building, and they're going to ride you till your elbow fails, and then the next group of kids will come in, and guess who's going to reap the results? You, as you sit, with your operation and your baseball career's over. So, we just have to be. We have to educate as much as we can, inform people of the risks of this stuff. Don't do the weighted balls if you're a young kid, especially skeletally mature. If you're a parent, put those weighted balls away. Bad idea.
Yeah.
Yeah, I think if we just work together to try and do this, we can at least reduce these a little bit.
Yeah, it's funny. This just popped in my head thinking about pitch counts and cumulative stress on the arm and volume and all that. And it's like, I think back to, now I'm talking major league pitchers here, but, pitchers back in the, 40s, 50s, 60s, even before that throwing. I mean, it was not uncommon to throw 9 innings. I mean, you pitched the entire game.
Yeah.
And
but back then, though, those guys would go work in the factory in the offseason.
Right,
you know what I mean? So there was
they were drinking alcohol in the clubhouse, smoking cigarettes in the dugout.
Well, that's the thing, though. But there wasn't pitching academies.
Right.
They weren't going to pitch in the winter.
That's true.
They put the ball down.
They
played other
have
sports.
time off.
When I was a kid, there wasn't these academies and stuff. Like we played summer baseball. In the fall, we played football, and we played basketball or hockey, and then we did it again next year. Now they're doing it year round.
Yeah.
And it's every sport. They're all doing it.
So
so it makes it really hard. There was a stat last year in the College World Series. They showed the picture of this gray-haired old man, and that he pitched 300 pitches basically in a day. They played 2 doubleheaders.
Right.
And I think he pitched a total of 19 innings. And it's like, he didn't have Tommy John. That's one day. I don't want to say, I'm not encouraging that by any means.
Right.
I'm just saying that, it was a different era,
Yeah.
Like we didn't pitch nearly as much. All the spin rate stuff wasn't talked about, and like I said, I'm not saying the stuff we're doing from a preventative standpoint has evolved for sure. Mm-hmm. But I think that those old timers showed us that you can have a long, long career if you just put the dang ball down.
So simple. Put the ball down when you're not working on for at least 4 months, right, out of the year, and just work on your overall strength and conditioning. And it's so simple. Yeah. It's really is simple.
It really is. But we have that competitive drive, and it's amazing how many kids are just at these second, third grade levels are moving on to more competitive teams and stuff like that. It's like, you don't have to do that, Mom and Dad. You don't have to.
Right.
And by the way, the main reason kids are playing, they don't care about competitive level. They want to play with their buddies.
Yeah.
That's why they play. Ask any kid. Geez, my own kids. Do you want to play this fall? Well, who's playing? And then once they find, I'm in. That's why they play. They don't want to know, are we going to go do travel? What cities are we going to go see? The kids don't care.
Yeah.
They're there to be with their friends. That's what it's about. That's what it's about.
Well, Dr. Lorenz, I really appreciate you coming back to the studio today to discuss Little League elbow and ulnar collateral ligament injuries. How can people contact you if they have any questions or need rehabilitation?
My number at the office here in Lawrence is 785-838-7885. You can reach me on email, danielslorenz@gmail.com, or I'm pretty active on X, so my name on X is KC Rehab Guy.
Thanks, Dr. Lorenz. Appreciate that. If you have any questions for me about the KU Exercise Science program, send an email to jtaylor@ku.edu or call 913-897-8516. I hope you enjoyed this episode of Fitness Facts, and thanks for watching.